and regional epilepsy, and talk about some of the concepts that have driven us to use this therapy increasingly for these difficult cases. And we'll talk a little bit also about the role of stereo EEG, potential role of stereo EEG in monitoring the thalamus prior to employing thalamic stimulation, sensing and stimulation, and in neuromodulation therapy. So let me just first acknowledge that we started doing central-median region RNS in Pittsburgh when I was there. Alexandra Urban's a neurologist who helped start the RNS program in Pittsburgh. I hadn't been involved with the clinical trial, so there may be people in the audience who've been using RNS longer than I have. There are two important people that moved with me from Pittsburgh to MGH. One is Vasily Kokonas, who's an epilepsy neurophysiologist who has a very active role both in our clinical program and on the research side. He's a very gifted neurophysiologist. And Nathan Sisterson was a data scientist in his former career who was a med student turned now MGH neurosurgery resident who's helped us build a workflow for RNS and data analysis. And then here are the folks on the MGH side that are participating now. Kat Chu started our pediatric RNS clinic, and Sid Cash has been directing our adult RNS clinic for several years. Okay, so these are the cases or the categories of cases, at least that I've kind of organized patients in thinking about thalamic RNS. The first one that's listed is the one that may be or may not have the least familiarity with, generalized epilepsy. And then I think kind of possibly descending in complexity, depending on how you think about complexity, bilateral multifocal cases, and then maybe more regionalized, say unilateral but diffuse seizure or hard to define seizure onset zone. We'll call that regional epilepsy. Let me also say, I'm happy to be interrupted with questions. I'm not sure what the usual format is, but Michael, feel free to pop in if someone puts something in the chat or interrupt me. Yeah, it's no problem. So let's first start talking about IgE and what the rationale would be for thalamic stimulation and specifically responsive stimulation. So I'm highly biased here. I think there's been an under-recognized problem, drug refractoriness in generalized epilepsy. And there's been evidence now for decades that the thalamus participates early in generalized seizures. It was part of the original rationale for implanting the thalamus, even in early stereo EEG cases decades ago in Europe. There is more recent fMRI data. I've got two examples here from a couple papers. You can really find a mix across the fMRI literature, but certainly there is some evidence for the thalamus essentially coming online. This is kind of right before when the time alignment is carried out related to generalized spike wave discharges. This is an example of the thalamus coming online early and before some cortical areas. And then this is another fMRI paper showing at seizure onset or this kind of run of spike wave discharges that the thalamus, you can see at time 0, comes online. So there's non-invasive data that supports the idea that thalamus is at the very least involved very early in the origin of generalized epilepsy. And when we thought about whether the thalamus could be used as a sensor for RNS, we went to the literature to look and see who had recorded in this intermediate nucleus before. And if you do that, you'll find the work of Velasco and others in Mexico City who were doing DBS for generalized epilepsy in this intermediate thalamus. And when they did that, they had the DBS leads externalized. They could record from them along with scalp EEG and sometimes with the use of paddle electrodes on the cortical surface. So this is an example from a patient, a tonic-clonic seizure on the left and a non-convulsive seizure on the right. And the RCM and LCM are right and left centromedian, we'll call it region recordings. And you can see that the seizure is evident in the thalamus, essentially at the onset of these particular seizures. In more modern data, the group at King's College has done a lot of work with DBS stimulation in generalized epilepsy, the centromedian thalamus. This is a nice paper. It just has 3 patients, but it's a thoughtful paper, really kind of works through the rationale of thinking about how different types of generalized epilepsy may involve the thalamus, and when the thalamus is involved. And this is a pretty simple time lag plot that shows the relation of onset, seizure onset in milliseconds. And so if something's very red, it started the signal is detected by their review 50 milliseconds before the corresponding region. So let's look over here at T1. You see they're more red and orange. And if you look across, it's the vertical compared to the horizontal, and you see the thalamus leading cortical areas. And that becomes, seizures become more diffuse and kind of more cortically oriented in later time periods. These are recordings on the thalamic leads. So the point of this is that, and these are from externalized leads, externalized DBS leads, patients that go back to the EMU and they have some decision process for how to proceed with the DBS. Okay. So a great way to think about what's connected to what in the human brain is to look at non-human primate viral tracing data, connectivity studies at the cellular level. And if you go through the literature, there's not a lot there, but there's certainly evidence that the centromedian nucleus is pretty widely connected. And that's not just, even though it is highly connected to parietal and frontal regions, it's also connected to the temporal lobe and to posterior areas. And when we thought about, well, what target would we use in responsive neurostimulation, knowing that the anterior nucleus is already an FDA-approved target in DBS, this literature that I'm reviewing now is really what drove us to try the centromedian nucleus, and just thinking that anterior nucleus probably not as widely connected to other brain regions as centromedian. Okay, and then there's of course limited open label, small case series, but nonetheless some reports of clinical efficacy of DBS, the centromedian nucleus, and that's specifically, sorry, just rearranging something here so I can see the slides. When you look through these case series of thalamic DBS, it tends to be the generalized cases that respond the best. At least that's my read of the centromedian case series. So here's an example again from King's College Group. And they took an interesting approach in trying to verify that their DBS leads in the centromedian nucleus were appropriately placed by looking for evoked potentials, in this case in the frontal lobe with the strip electrode that's placed temporarily through the burr hole that they use for DBS. So one of these would be on one hemisphere and one on the other. These are the leads in the centromedian nucleus, and it's stimulated and looked for evoked responses, and presumably use those to determine which contacts would be used in simulation, possibly to adjust the location intraoperatively. So this is not an approach that we've used for placing the electrodes because I haven't been able to sort out exactly the best way to determine where to put the cortical strip electrode. Maybe that's not important. So this is something that we haven't started yet investigating on our own. But just look at their data among these types of epilepsies. You break out the generalized epilepsies. You have some people who very clearly respond well. Again, open label data. This is a review by a South Korean group of thalamic DBS. And the thing to highlight here is that the gray circles that kind of focus around the centromedian nucleus are their generalized epilepsy cases. I've circled this is an ACPC space, anterior commissure, posterior commissure oriented space, specific to these Shalton brand atlas. So that's these images are slices through the Shalton brand atlas, which before the advent of other kind of more modern atlases that we use, including atlases that are in software that we can use post hoc, like Lead DBS, and in some of the newer planning software atlases. This is based on one patient's brain, and I'll come back to why I'm pointing this out. But nonetheless, if you look at the generalized epilepsy cases, again, there are only 3. They tend to cluster pretty well, and seizure reductions, not bad for these people that are really highly refractory. All right, so with all this evidence, and then you have this. I take all tractography and connectivity studies with a grain of salt, because there's really subjectivity in how these analyses are done. But nonetheless, these studies are useful. And Andy Horn, who is a neurologist who created this open source software platform called Lead DBS, which is honestly kind of revolutionized the way that we think about DBS lead placement and, for instance, movement disorders in OCD using connectomic modeling. I think this will have a role certainly in neuromodulation and epilepsy, and helping us understand what we're doing when we're successful or when we have failures, therapeutic failures. But there is an association with engaging a certain part of the structural and functional connectome. For instance, in this case series, this was a group of patients from Mainz, Germany, and also Barcelona, who underwent intermediate DBS for generalized epilepsy. Or this may be Lennox-Gastaut. It's probably a mix. Okay. All right, so let's pause here. And this is a common question. You might say, well, internucleus DBS was already proved. You're interested in using this, using neuromodulation and in generalized epilepsy, why not just use DBS? I think these are important additional areas of value with the recordings. And the caveat is using the RNS does require a lot of work. There's no doubt that it is more work. It's more work for the patient, it's more work for the epileptologist. You have to look at the data. It takes a lot of time. But it does seem in our practice, and there are publications now coming out on the use of the intracranial EEG data to help with medication titration. It is objective data. So even though one comment I've heard is, Mark, we track seizures clinically. I do think that it's valuable to have this data. We know through a couple publications now that there are these multidian rhythms in people's seizures. So there's the opportunity to provide this data back to patients about certain periods in their day or week or even month when they may be more likely to have a seizure. And I think that technology, in terms of returning the information back to the patient, is only going to continue to improve. I think that'll become actually a very important part of the therapy. And we have a bias that we like to study the data. So we have a whole platform that I won't talk about today, but that's set up to analyze the RNS data. So I tell patients about that when we talk about options, because certainly we are biased there. All right. So what about the general strategy in terms of, should this work? So this is one very simple way to think about generalized epilepsy. If you agree that the thalamus is potentially primarily involved, you have this is meant to represent 2 hemispheres of the brain. And the idea of detecting and stimulating the thalamus is that you can widely affect these areas. Now, this schematic would be no different than what you might expect with DBS, the exception being if at any point we're able to show that there's a benefit to truly responsive neurostimulation. Right now, I don't think we have any evidence that if you didn't do DBS, so this intermediate, you wouldn't get the same results that we've been seeing. But my thinking on that has been that it should work better. We should be able to make it work better if we can figure out how to use the data correctly. So this is the general idea. Okay, so what about our own? Let me just check the time, make sure I don't stay on time here. So our adult IgE experience. So we published a case report a couple years ago in neurosurgery, and this was an interesting patient. She was, I think, 19 years old at the time. She considered herself an amateur singer. She did not want VNS. She had run into side effect issues with medication, and we proposed doing centromedian RNS. She had Javon syndrome, so absence seizures with eyelid myoclonia, and she was having 90 episodes a day, sometimes losing consciousness. So this is her scalp EEG in A, and this is just the spectral content of the seizure so that we can compare it to the data off the RNS. Here the raw voltage tracings off the RNS device. These are bipolar channels in the left and right centromedian region and the spectral content. And the point of this figure is to demonstrate that the seizures that are recorded in the thalamus are essentially what you see on scalp EEG. It's classic generalized spike wave discharges. So this young lady had a great result. Her seizures decreased by 90% by her count. She stopped losing consciousness, and she stopped taking her medications on her own against medical advice without any deleterious effect and without any effect in her recording. So we were enthused by this result, and we continued to offer this to patients. We finally got this packaged and out in print now. It's just first 4 patients from Pittsburgh. So again, it's not a huge experience in press yet, but nonetheless, we continue to see some significant results. And these are people that are really highly refractory. So I'll point out a couple things here. One is medication reduction. And these are I'm pointing out a couple things beyond the Ingle score, which I'll talk about in a minute, and then seizure severity. So if you look at the Ingle score and you think about this related to our typical goal for an epilepsy surgery, which is resection and cure. And we think if the patient has a seizure again, then we failed and we didn't cure them, even though I don't entirely think about resective surgery that way anyway. I think as long as the surgery is done well without any complications, you can certainly modulate seizure circuit in major ways and improve patients' quality of life without making them seizure free. But of course, it's always a goal to make them seizure free. Neuromodulation is different because we don't expect there to be a cure. And so one perspective on this is, oh, well, is it worth it? You put the patient through surgery and you're not even going to stop the seizures. The patients report to us that it makes a big difference, even when, for instance, you have an Ingle score of 3A. So if we did that if we did temporal lobectomy on someone, they were Ingle 3A, we'd say, oh, we really messed that up. We have made some mistake. But our thinking, I think, with neuromodulation, RNS and DBS needs to be different. This particular patient who is Ingle 3A had been hospitalized and intubated 6 times in the previous year, and had not had a convulsive seizure, and I think maybe hadn't lost consciousness after implantation, even though he continued to have seizures. So seizure severity is a big deal, and some patients are able to significantly decrease their medication. So again, this is just 4 patients. So what's happened since then? So at that time, then I made the transition to MGH, and took a little while to get up and running, but we are implanting both kids and adults with IgE in the centromedian region. We have 3 more patients here, at least at this stage. Again, they're young. Some of these patients, at least one of them, I think really has a JME diagnosis, and they're 3A. So again, not Ingle class 1, but these are significant improvements, and these seizure outcomes translate into really significant improvements in quality of life. So I think one thing we need to do as a field is do a better job of capturing that. These are the some histograms of long episodes from the RNS device. And what we expect to see, these are probably the best correlate of clinically irrelevant seizures, or certainly of epileptiform activity detected on the device. They're not a perfect correlate of epileptiform activity, but they're close. And we would expect these to go down over time as this happened in patients 2, 3, and 4. Patient 1, it doesn't look like anything's changing. What you see these large gaps in the data. And this is very interesting because the way we interpret this is that with these large gaps, we're probably not seeing the expected trend. And one point of having this in here is that the more we can encourage the patients to download the data, the more useful the therapy will be for them. But this is an important component for sure. So one thing that I think will be helpful here is the development of more automated tools so that it's easier to give the patient feedback and there's more of a positive feedback loop in terms of the value of downloading the data. Something I think we can aspire to. And so these are some figures from the paper that show the different recording and stimulating locations. And one thing I'll go ahead and point out is that these electrodes, for the most part, are skiving the centromedian nucleus and are not really in the middle of the centromedian nucleus as we would expect them to have been from using the Schottenbrand atlas. And we detected this when we started looking at our lead locations using the software called BDBS, which has very modern subcortical atlases. This particular patient does have detection and stimulation in the centromedian nucleus. It's color coded here, and you see examples of seizure onsets and detections and stimulations. And just kind of breeze through this for the time being, just to show you that some of the efficacious locations resulting in significant efficacy are not the centromedian. You know, they're out here. This is ventral posterior lateral thalamus. So why is that? We're not sure. We're still parsing through this data and the newer data to figure out the differences in location-specific responses. This is something really important that we need to figure out. But again, this is, I hope that this ends up being an example of why the recorded data is so valuable, as opposed to just turning on stimulating and hoping for the best and looking at where the leads are without some of the intracranial data. And those figures lead up to this point, which is that when we realized that we were not doing a good job of putting the electrodes, the leads in the centromedian nucleus as we intended, despite the fact that the efficacy was good in these first few patients, I changed the targeting to match the intended target because that was our initial goal. It's not clear whether these patients are responding, but it's not clear whether that change is beneficial or inconsequential or detrimental in terms of outcome. We just haven't done enough cases, but I will just point out that the yellow leads were that original case series of 4 patients, and then the other implantations when we've used more modern atlases and changed the thinking on our targeting, also following a paper that came out from the Melbourne group doing DBS in this region. Now that we changed our targeting, and I need to update this. We've implanted more patients than this now, but we'll see over time as we do correlations with intracranial EEG and the anatomic locations. It's just something to point out, and it just shows that these areas are very different. This is the sensing locations. SAB is Schottenbrand atlas, so that would be here. MAB is Morel atlas. Oh no, MAB. Oh, this is Schottenbrand method. This is Morel method, and the green is the Morel atlas of the thalamus. So basically, this is the way we're doing it now is the blue. So that's here. Anyway, the point is that these locations are different now. So we'll see. All right, what about kids? So this is a 10-year-old with generalized epilepsy who underwent bilateral intermediate nucleus implantation. This is just in case you're not aware. This device, even though it's off-label for IGE, it's off-label for kids too now, but at least 10 and younger, 8 years old, no problem to accommodate the device, the cranial implant. This is what so we have 2 incisions here for the burr holes for centromedian lead placement, and then we do kind of a U incision back here for making the craniotomy that will hold the RNS stimulator. All right, what about outcomes in kids? So this is our initial case series. You can see we have, here's a 2, we have a couple 3s, and then we have these people who really have not responded. And we're trying to understand why that is. Mistaken patient selection, is it a lead issue? Is it a programming issue? There are a number of reasons why we may not be seeing a response here. So we're in the process of sorting that out. You do see that seizure severity decreases in these kids who are responding. Okay, moving on to, and here in a few more slides, and we'll talk about stereo EEG. So this example of kind of similar approach to bilateral multifocal epilepsy. So let's say you have someone who has diffuse polymicrogyria or malformations of cortical development. If we were thinking just in terms of resection, it might be less likely to do a stereo EEG or consider any type of surgery. But with the ability to both sense and stimulate, I think this sets up a number of questions that we're obligated to at least think about, if not investigate, for these patients, depending on their seizure semiology and the quality of the non-invasive data. But in some of these cases, might be possible to hypothesize that even though there are broad areas that are affected, there are more focal components of the multifocal network on each side, might be in different locations. And here in some of these cases, we've done stereo EEG first to drive these decisions, but instead of detecting and stimulating at one part of the cortical circuit, we might detect at different cortical locations. Obviously, we can't detect all of these, but stimulate in the thalamus to get a broad response. And similar thinking here for regional epilepsy, where in some cases we would use stereo EEG to try to sort out whether we would use the thalamus for stimulation, probably assuming the detector is somewhere in the cortex for regional type of epilepsy. And the Spectrum group in Michigan and David Burdett has talked about and presented on this, for instance, using the pulvinar for posterior regional epilepsies. Okay, so I think, yes, so that brings us to the possible role of stereo EEG in thinking about RNS specifically. So really evolving, thinking about how we do diagnostic surgery, where it's not just to delineate an area of the brain that could potentially be resected, but for mapping the network in a way that if resection is not an option, we understand things well enough to make an informed decision about whether responsive neurostimulation might be used and where the detector would be and where we would stimulate. So we have a very simple way of thinking about this, which is just related to the onset of the seizure. And so we're now implanting the centromedian nucleus. And I think maybe we've done 2 cases now where we've implanted more than one thalamic location on a given side to try to answer this question about whether seizure onset is observed simultaneously or near simultaneously in the implanted area of the thalamus in relation to the cortex. And if the thalamus doesn't lag, then it's a potential detector and potential area for stimulation. If there really is a lag, essentially a seizure is propagating through the thalamus some later stage, once it's already evolved, then maybe we're better off doing cortical RNS. Here's an example of including central median nucleus in the stereo EEG case. So this is someone, I abbreviated these slides. I don't have the background, but you can see polymicrogyri all over the place. And this is someone who nonetheless had focal semiology that we felt warranted investigation for whether, in some of these cases, we might consider ablating a particularly active part of the seizure network and performing neuromodulation on another part, or potentially resection. In this case, we ended up with a bilateral, probably not entirely symmetric implantation, because we would have targeted some regions that were anatomically the most disorganized and that matched some of the other non-invasive findings. But we ended up with this on the intracranial EEG, and you really have to turn up the gain to see the signal from the thalamus, because the neuronal architecture is different than the cortex. So these do have to be adjusted differently. When you're reading the EEG, but you can see the seizure onsets detected near simultaneous in the central median nucleus on both sides. That's the LCM and the RCM. So this patient, because there wasn't a clear cortical area that we felt was better suited for detection or stimulation, and with only 2 leads on the RNS, were somewhat limited in terms of the amount of cortex we could cover, we decided to do bilateral central median RNS. And there's some recordings. You can see some detections in the thalamus and stimulation. And here were his baseline seizures, 3 to 7 seizures a week. I think that's what that's supposed to be. Now with shorter seizures, less severe, he's not falling. So this is someone that may be meeting Engel class 3 at this point, but who's having significant improvement in quality of life, and otherwise would not have been deemed a surgical candidate at all. Another example. So I think in the practice so far, we've done stereo EEG in 2 people who it wasn't clear whether they had generalized epilepsy. Certainly part of the hypothesis, but they had focal features in some component of their non-invasive data, the semiology. And this is one of them who, based on the intracranial EEG, did end up with a diagnosis of genetic generalized epilepsy. But here's the data. So she was 20, and I won't read this to you, but some focal components for semiology, suspicious MRI abnormality. And these are our hypotheses for the implantation. This is what her implantation looked like. And again, what we saw was something similar, where the onset is detected, very early, and the thalamic leads essentially simultaneous with cortical onset. So this is someone that also went on to bilateral central median RNS. We have had cases where we implanted the thalamic target and have not used it because the seizure did not propagate through the thalamus, at least the location that we implanted, in some seizures, or propagated through the thalamus late. So I've shown 2 examples where we ended up with implanting central median, but they're not all like that. Oh, sorry, this is just the other side. I showed the left side. This is the right side of that particular patient. Okay, so this is kind of wrapping up the presentation here. This is a chart that's really meant for kind of discussion and thought experiments, as opposed to recommendations for exactly what we should be doing. But there are 4 clinical scenarios. The SEG implantation in each scenario could be standard, which in this case means does not involve the thalamus. or involves the thalamus. There are different interpretations of the seizure onset zone, essentially with and without early thalamic involvement. That's what ETI stands for here. And then there's some options, and I need to do a better job of color coding this so it's more, it's easy to interpret. But in this case, you have someone who, say, they have bifrontal epilepsy. If you don't implant the thalamus, you don't know whether the thalamus may be a good place to sense or stimulate. And maybe you have a little more limited therapeutic option. If there's early thalamic involvement, then you can consider how the thalamus is used in a neuromodulation strategy. At some point, we will have more than 2 leads for these sensing-enabled devices. The RNS is not the only sensing-enabled device. Now there's the Medtronic Percept device. I don't think that will be the last responsive cranial implant that we have. So I do think there's some value in thinking about this now. And in some patients, I think this type of thinking potentially can make a big difference. What the main thing I think we're trying to avoid here is being too limited in the brain that's sampled or targeted for therapy. And if we miss an opportunity to do broad simulation where that might be more efficacious, then potentially we're leaving some quality of life improvement on the table for the patient. But of course, this is to be determined, to be proven, really to show this empirically. So we can go through these other scenarios, but essentially involve the same thing, which is you include the thalamus, you have some other information, and you might then involve the thalamus in your neuromodulation strategy. Here I've thrown in anterior nucleus. So I didn't put slides in, but certainly happy to talk about it. I think in 2 cases now, one of which was a patient who had bitemporal RNS. At some point, he had had a battery replacement. It had gotten infected. The RNS had been removed. And by the time I saw him, he said, I'm not sure that ever worked really that well. And so we repeated his stereo EEG. We included the anterior nucleus of the thalamus, thinking maybe he needs that as part of the strategy. We want to make sure that the previous investigation that he'd undergone didn't miss something. He had bitemporal, bihippocampal onsets, is very clear. And so we implanted him again in the bilateral hippocampi and didn't use the anterior nucleus. And in that case, where you think if anything's going to propagate through the anterior nucleus, it would be maybe a bitemporal seizure network. We did not see very impressive signal in the anterior nucleus. And we've had another case where you implant the anterior nucleus and it wasn't impressive in that particular case. Doesn't mean that's not useful. And I've listed it here. You could substitute this with pulvinar or another thalamic nucleus of your choice based on your ideas about seizure networks. And I think we'll see more and more of this. There are other groups that have been more aggressive. I don't like to use the word aggressive when talking about surgery because I think it's appropriate, but have used already multiple thalamic targeting in their stereo EEG, even bilaterally. So we're slowly kind of evolving this, but we've really tried to make this hypothesis driven and personalized to particular patients. So when we make a step in doing something different, it's really about a hypothesis that's patient specific. And I think this is my last slide, conclusions and questions. So we know that thalamic RNS can work. We know DBS can work. We don't understand exactly how it works. We haven't, in our own group, even touched the neurophysiology of this yet. We have one paper where Vasily Kokinos manually identified changes in spectral patterns of seizures in patients who were responding very well clinically that did not show up in patients who were not responders. We have a paper on that, but we haven't looked for similar effects and in the generalized cases yet in our thalamic cases. And it could be that there's something very, very different there. And that paper, which was all traditional, more focal, or maybe some multifocal cases, but all cortical-based stimulation. Those patterns did not seem to directly result from individual stimulation events, but accumulated over time, suggesting that there is some modulation of the network. But we're in the early days of understanding how thalamic responsive neurostimulation could change the overall network. We need to do a much better job at this. I think certainly one of the reasons that would explain heterogeneity in results across different types of generalized epilepsy, different types of IgE. I've used the term IgE, but of course that not all IgE is the same. So we have ways to go here. There are things that maybe we could do in the operating room as we understand better from looking at our lead locations and the physiology. We can potentially understand how to improve the implantations with intraoperative neurophysiology. Okay, so I've said that, and the role of SEEG is evolving. And so I will say one thing about, one common question about the safety of implanting the thalamus is it safe? And from the perspective of someone who also is a movement disorder surgeon, which means DBS, where we put leads all the time in the basal ganglia and, for instance, the thalamus and the central tremor with very low rates of morbidity, I haven't, in my mind, there's not much of a difference of putting something in the thalamus versus, for instance, putting a stereo EEG electrode through the sylvian fissure into the insula in terms of risk. And we have not had a problem with this. And so I do think it's quite safe. Obviously, or I wouldn't have done it. And I think the potential benefits far outweigh the risk. That's my perspective. Okay, Michael, I think that's my last slide. I'm happy to take questions. I hope that was helpful and interesting.
And Mark, thanks so much. That was a wonderful talk. It's really exciting for us in the epilepsy world. We have a lot of the same patients, as you can understand, and we've been working with RNS for years here at Swedish. And we've just started teeing people up for some of these thalamic stimulations, and we argue about this in our conference all the time in terms of who's a good candidate and how best to choose them. It's just a wonderful new way to look at, say, just the physiology of the thalamus in general, especially when you drill down on some of those circadian rhythms and triggering timing, ultradian rhythms and things like that. We're happy to collaborate. We certainly have tons of data, but let's jump to the questions. Katie Carborbun, one of our epileptologists, has a couple. One, a comment. One was whether or not the anterior nucleus might not be easy to target. And the second was, how is it that you're programming to respond to the seizures? Is it more of a DBS-like regular pulse, or is it a responsive programming similar to the cortical onset folks?
Okay, great. So the anterior nucleus question first. It does seem from the DBS experience that the best way to target the anterior nucleus is through the ventricle. So that probably does have an increased hemorrhage risk, although maybe small. So for instance, we have not done that in our SEEG implantations. We've come through cortex to get to the anterior nucleus. I think it's not that's not the final answer in terms of the best trajectory to the anterior nucleus. That just happens to be the DBS experience. I think probably the best answer to the difficulty with targeting the anterior nucleus is it is small, and so you have less room for error. I think for the most part, the size of the electrodes we're putting in terms of well, I won't say that. It does seem that proximity, for instance, the mammillothalamic tract could be one of the things that's most important for anterior nucleus efficacy in DBS. And I guess the only other thing I'd say about that is we probably don't have a great understanding of propagation pathways and connectedness of different thalamic nuclei. At the level we should to think about. At least I don't. In thinking about the best way to target different parts of the thalamus. Related to how the stimulation is done, the pulses are longer, so they are more of a Sante like pulse duration, but it is responsive. So we don't have it turned on so that we're just trying to detect as much as we can and we're blasting it. The detectors are set up in the same way that you would set up your detectors for a focal seizure that's cortical somewhere. So we do try to titrate that as best we can. I was concerned when we moved here in the first bilateral central median patient we implanted did not seem like he was responding. I thought, oh, great, I changed the targeting and this is just going to be a failure. And we realized that the stimulation was not set up the way it had been done in Pittsburgh, and we fixed that. And the other thing we found is that it does seem like it's better to get to higher stimulation amplitudes faster. That's helpful. And then the other part of this question I think is interesting is side effects. So we do see side effects. We present a paper at AES, and my PA, actually Nora Daly, is working on writing up how we've dealt with stimulation side effects, because people can have sensory percepts that we can program around. One of the epileptologists we work with in town, Joel Oster at Tufts, has, I think now maybe even 2 patients we've implanted where the device goes on, they don't have an aura that they're having a seizure, but the device produces an aura that they find helpful because it produces a side effect that's maybe a mild tingling that the patient, we thought, well, let's see if this wears off. And the patient actually finds it helpful because like a seizure warning that they wouldn't otherwise have. So that's, so Joel has derived that.
So there's a bunch of other questions. 3 of them, I think, sort of lump in the category of side effects and safety and tolerability of targeting, which I think you kind of just answered. So we may skip those unless you want to go back to that. 2 of them are a little more neurosurgical based. Dan DiLorenzo from Loma Linda wanted to know what stereotactic coordinates do you find best for CM?
So what I call our new consensus coordinates are based on the ACPC midpoint, and it's in the ACPC plane. So Z is 0, and it's lateral 8 and posterior 9. So plus minus 8 and negative 9. I still have to look that up when I do the case to make sure I haven't confused them, but that's pretty close. And then what I did is if you look at this paper by Warren et al., which is in JNNP and talks about central median targeting, so we use the MP2 RAGE sequence. In that paper, they have a fancy post-processing edge contrast thing, which is, I think, done on GE scanner that we can't do because we have Siemens. But the MP2 RAGE is helpful, and there's a hypodensity that is best seen if, at least seems to us, if you start with those coordinates and then you go back up 3 millimeters above the ACPC line. Because if you look through that paper, you'll see that at least this was our interpretation, that the ACPC plane where the central median nucleus was best visualized was 3 millimeters above the Z of 0. And I'm happy to talk about that more if you have any follow-up questions about that.
We got a hardball neurophysiology question from Dr. Sotero from our PD epilepsy program. Marcio Sotero wants to know, do you use intraoperative CM stims to look at your ECOG fast activity to check if your position is good, kind of like the Velasco team did?
We haven't done that, but honestly, I think we probably should. I haven't derived yet a protocol for doing that, but I think there probably is some utility because otherwise we're there, we're recording, we record from the RNS and we're not using physiology. Question is whether the patient has to be awake. So when we started doing this, the first few cases, and this was new, I was hesitant to do too much that was new. I thought we'll implant and see how it goes. I did one of those 4 cases I did do with the patient awake and did microelectrode recording to see if that would help with localization of the different nuclei. And that was right before this paper that I've mentioned from the Melbourne group came out. My interpretation of their MER recording was that it wasn't helpful. I also did not find it helpful in that N of 1 experience. And so I haven't used microelectrode recording, but yeah, if anyone wants to think about, wants to collaborate on the best way to do that, I'm happy to think, but we need to think about it more. I think we're missing an opportunity to work with the physiology in the operating room. But perhaps the patients have to be awake, perhaps they don't.
So Mark, I'll tie things up. Thank you again for that wonderful talk. A couple of ideas there. I really love that idea of surveying the thalamus along with the other stereo EEG sites just to triage your decision-making a lot quicker to an actual therapy. The other one's more of a speculative is we've talked about the epilepsy angles for RNS. We haven't talked about the movement disorder angles for RNS and whether or not using that as a responsive device for movement disorders. Are you doing that or interested in that or theorizing on that in your functional lab there?
Can you be, I'm not sure I completely understand the question.
So if you're targeting thalamic sites for, say, ET or Parkinson's or even, more bizarre movement disorders like Tourette's, have you used RNS or thought about using RNS for stimulating in different ways other than just pulses and sequences?
I haven't done that, but it's interesting that you bring that up because I went to a DBS meeting. It was one of the first meetings I traveled to several weeks ago. And I started thinking about this more. And there's really no reason that the RNS couldn't be used as a closed loop device and for Parkinson's DBS. I don't think the way that it's, for instance, tracking beta frequency. But no, I have not done that.
Well, thanks again, Mark. Wonderful talk. It's good to meet you online, and thank you for participating in our Swedish Grand Rounds. We really appreciate it.
Okay, thank you. Yeah, enjoyed it. Really appreciate the invitation.